So, welcome guys. We'll be discussing about 10 spotters and various DDs. So, this first image here, only with image, there are so many DDs for hyperintensity. Okay. But when I give you the history of Korea with diabetes mellitus, then there will be only one DD for T1 hyperintensity in the basal ganglia. So, basal ganglion T1 hyperintensity. As you can see, there is hyperintensity in the putamen and the caudate nucleus. So first one, which sequence is this? As you can see outside, gray matter is gray and inside white matter is white. So just remember that T1 is the sequence which follows anatomy. In first year, we all study with subject anatomy. So, if the gray matter is gray, white matter is white, it is T1 weighted image, and you can see unilateral T1 hyperintensity, not bilateral, unilateral. And one more thing to remember that if the patient is having hemicoria on the right side, then the lesion will be on the left. Okay, so here since the lesion is on the right, patient presented with left hemicoria with increased blood glucose level. Yes, the answer is non-ketotic hyperglycemic hemicoria. So in this spotter, it is clinical plus radiological diagnosis. There are many DDs for increased T1 hyperintensity from subacute hemorrhage to Wilson's disease to carbon monoxide poisoning, many more things. So this was the spotter number one. As I told, I have written all the DDs for increased T1 hyperintensity, starting with the metabolic cause. Metabolic is non-ketotic hyperglycemia. In case of liver injury, so that is manganese deposit, copper deposition seen in Wilson's disease. At subacute hemorrhage is the most important one, which we have to remember. And here hyperintensity is because of deposition of methemoglobin. And in case of carbon monoxide poisoning, it is a one substance which will injure your basal ganglia. So there is T1 hyperintensity. Coming to spotter number two. So in this spotter, as you can see, there is widening of sylvian fissure. Okay. With widening of sylvian fissure is giving appearance of something. Yes, it is batwing appearance. Batwing appearance of the sylvian fissure because of its widening is nothing but another condition known as glutaric aciduria, and this is type 1. So answer for this spotter is glutaric, sorry for my handwriting, aciduria type 1. Okay. So, and one more thing, here we can see that on flare it is suppressed. On T2, it is hyperintense. And in case of and along now you can tell how to rule out it from other conditions. It will also involve basal ganglia hyperintensity. So the condition which is having basal ganglia hyperintensity along with that widening of the sylvian fissure is glutaric aciduria 1. And in this example, you can see there is hematoma. So what happens is because of widening, there can be rupture of the veins. So it will cause the hematoma. So this is the diagnosis of GAA1. Hello. 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 Ma'am, your order delivered. Okay, okay, thanks. Now let's go to next spotter. So this is I have given the DD. What is the hallmark or the tired of GAA? It is having frontotemporal atrophy. We saw that in brain there was atrophy. Okay, with atrophy there was widening of the fissure which was giving the batwing appearance, followed by basal ganglion hyperintensity. Remember, it will be having basal ganglion hyperintensity. Now, what are the DDs? Uh, in children, if we see this subdural hematoma, we should rule out NAI, but it will not have basal ganglia hyperintensity. And also, if cerebral atrophy, it will be diffuse. This is mainly frontotemporal. So, one mnemonic to remember is this is GAA, glutaric aciduria A, that is type 1. You remember, it's like a guy. Guy means cow. Okay. So, we are having all the animals. We are having cow, we are having bat. So, it is having batwing appearance. It is nothing but GAI. This is coming to next one more important spotter. So this is nothing but midbrain involvement of artery of Percheron infarct. We have seen many cases of artery of Percheron infarct involving the thalamus, which is yes most common. But again, this is also seen. This V-shape appearance is seen when it involves the midbrain. So artery of Percheron, as we can see, this is a PCA. PCA ka branches supplying both bilaterally. But in case this is a variant in which there is only one PCA, one branch present, and that P1 segment, it is supplying the thalamus here. So if there is infarct here in this, both the thalamus will be affected. And one more important DD for bilateral thalamic infarct, we have to remember Japanese encephalitis also. Okay. So one DD, artery of Percheron, that is most common. And also we have to rule of internal cerebral vein thrombosis. And Wernicke's encephalopathy will also have the hyperintensity in the mammillary body. Coming to viral encephalitis, as I told, Japanese encephalitis is the most common. So, what is this diagnosis? Our fourth spotter. Yes, this is a case of left upper lobe collapse. Okay, so here we can see the classical Lufsical sign. That is nothing but because of the collapsed lung segment, the superior segment of the lower lobe will expand, and it will expand in the sickle shape because of the space between the mediastinum and the collapsed lung. So this is nothing but the left upper lobe collapse. Along with that, here we can see the veil-like opacity. Okay, and here what is seen in lateral radiograph, I want to tell about one more sign which is called spine sign. Spine sign is more specific for posterior lobe pathology. So whenever we are considering AP radiograph, it will mainly involve the upper lobe, but on the lateral sign is specific for posterior lobe pathology. It can be collapse or pneumonia, anything. uh, the physiology behind is that, see, upper big body, because of lot of musculature, this will be more white. Okay, we'll be not able to see. But as it passes down, in general word, if I want to say, it will become more black because rays will pass directly. But here, because of the collapsed lung, the rays won't pass. Hence, this will appear white. Here you can see, no, it is white compared to upper vertebra. So this is spine sign. And one more sign that is seen again in the collapse is silhouette. The hard border will not be because we will be not able to make out the hard border. If the lower lobe will be collapsed, it will silhouette the diaphragm. And also spine sign, as I told. And one more sign is called waist sign. That is, the collapsed lung will be seen like a waist. Okay. Coming to fifth spotter. So this is nothing but pectus excavatum. Okay. So it is one of the most important and confusing spotter because we'll be thinking it mimics many other things. Okay. So I'll be telling few important signs on X-ray and what is the index which we in CT. So in X-ray, we can see that the right heart border is not clear. Okay. This is nothing but the breast shadow. We should not get confused with it. So the right heart border is not clear. That is the first and most important sign. And second sign is breast sign. That is the medial border of the breast. Okay. The medial border, as we can see, it is very much clear. Normally, it is not seen. So this is the clear appearance of the breast sign. Then Third is uh, the anterior ribs will be more tilting down or sloping, and posterior will be more flat. Hence, it will give this heart appearance. Okay. And here we can see lateral is the diagnostic, because here we can see this dip. This is nothing but excavatum. And in CT, we use something which is known as Haller index. You might be seeing this in reporting. And if it's more than 3.5, it is excavatum. Uh, and homework for today is what is Haller index and how we measure it. So this is the next spotter. Whenever we see this appearance, which is iso to hypo with all this mottled appearance, whenever I use the word mottled, we have to remember it is either trichobizar or the gauze piece left if there is surgical history. So this was a trichobizar, and in the it will perforate and there is pneumoperitoneum. Again, in the coronal image, we can see clearly this is a hair. It caused gastric obstruction and there was rupture over the lesser curvature. Coming to seventh spotter, this is the case of empyema. Now, what is the difference between empyema and pleural effusion? So, if pleural effusion ka fluid becomes infected, it will become empyema. And in empyema, we can see on contrast, it is lenticular opacity and it is showing smooth enhancement plus thickening. This is the word which should be there when we use the word empyema. Enhancement plus thickening plus lentiform. And what is the sign? Because of this thickening and enhancement, it will split the flora. This is the collection which is loculated and it will split. Hence, it is called split pleura sign. Sorry for my pen. So, now next question is, what are the complications? We have to remember this is the most important Viva question. What are the complications of empyema? First, it will communicate with the lung. Okay, if it communicates with the lung, we call it as bronchopleural fistula. If it communicates with subcutaneous tissue or chest wall, we call it as empyema necessitans. You might have heard this, and it's the spotter also. There will be collection like this. It is connecting with the chest wall. So this is empyema necessitans. Later on, it can form sepsis, it can become fibrothorax, etc. And what is the management? Is it only by draining, by putting ICD? No. Surgery should be done and it should be drained, because or else it is not gonna decrease. Coming to last but two spotter. Yes, we can see well-defined cystic lesion in the floor of the mouth. Few words that you have to remember is floor of the mouth. Okay, it's ranula. It is involving the, see, easy way to remember is L. Ranula involves the sublingual gland. If it becomes plunging, it will go after L alphabet M. So it will go to submandibular gland, while piercing mylohyoid muscle. So two M's. This, and it gives a sign. So this is tail sign or comet tail appearance, where from floor of the mouth, it is going to submandibular gland. So these are few things you have to remember. Now one more question. If this ranula, now we can see that it is cystic. So if I do MRI, does it show diffusion restriction? No, it is a clean cyst. Cyst will never show, like arachnoid cyst. But if it shows diffusion restriction, what is it? Yes, it is epidermoid. Just like epidermoid in brain, this is the epidermoid cyst which will be having gelatinous material and it will show diffusion restriction. Coming to last but one spotter. So here we can see tonsillar herniation. This is nothing but Arnold Chiari malformation. I know you all will be knowing this. In next spotter, I'll be teaching you how to remember each of it. Last spotter, T2 hyperintense fluid. On flare, it is completely suppressed. Diffusion restriction not there. Yes, this is nothing but arachnoid cyst. I'm really, really sorry for my pen. And if it shows diffusion restriction, it will be epidermoid cyst. Since arachnoid cyst is made up of clear CSF, it doesn't show. Epidermoid cyst will be having lot of keratinous and gelatin material. It will show. Okay. So that's it for today. Thank you.